I just would like to say thank you for that, Calvin, but
It's
you're very much
lovely.
underselling what the fellowship was. Just one of the most it's sort of inclusive and encouraging environments I've ever been in, and it changed my life. It's changed. There was so much stuff about how to use power, how to gain power, how to use that in a really inclusive way, and also to believe in ourselves. And I think Calvin's definitely not selling it in the way that it should be. I have never been in a learning environment that has been so safe and so supportive and so nurturing. And actually, every single person we met on that fellowship, be it the fellows or every single person that came to speak to us, they was just absolutely amazing. And we got to meet Janet Fowle. I mean, she changed my project. I'm going to talk about that in a moment. And we got to meet Ruth Oshikanlu, and it was her that inspired the way I shared my story. And also Dame Elizabeth Anionwu herself, who wrote her book, Dreams from My Mother. And it was those two people really that made me share a story, because we would set a task for the fellowship event where we share our learning and also talk about our change project. Now, all of those things that I gained, I didn't expect to gain. I only wanted to go and get help to make this change, because it was just trying to get some help from some experts. And I never ever experienced or thought I'd experienced all of these things for myself. And I wouldn't even be here talking to you today if it wasn't for that fellowship. So, Calvin, you're very much underselling it, but you are just absolutely amazing. So, and the course was phenomenal. And just having that opportunity to meet so many wonderful, passionate people. And I felt that we kind of met our people. To be in that space with people that have that level of passion is incredible. So to every single person that came and spoke to us, like Joan Myers, we had Roxanne, we had we had so many people that just fantastic. But yeah, it was an incredible privilege. So what I'm going to do now is I'm going to share with you the presentation, an audited one that I did on the fellowship event, and it's in two parts, but I'm just going to read straight through. And it will first just to demonstrate the importance of inclusion and our role in the NHS to do that. And the way I'm going to do that is I'm going to share my story. So I'm going to just share on here some slides. Can you see my slides?
Mhm.
There you go. Can you see that?
Yes, we can.
Yeah. So the story is a story of sharing light, very much inspired by Ruth and Dame Elizabeth, because that's how they talk about power and sort of privilege, and how we use that as a light and share it, and how important it is to share light, because by doing that you make it brighter. So I'm going to just share with you my story of privilege and power. And so in honour of Dame Elizabeth. So firstly, we've already had some talking, and I want you to just consider what you may have considered about me so far. So obviously I'm white, I'm a woman, I'm middle class. You may have assumed I'm professional. You may have assumed I'm heterosexual and I'm cisgender. And you may have also assumed that I like cake, and I ate that piece of cake. And if you're watching this in HD, you may have also noticed that the menopause fairy has gifted me a beard. Thanks for that. For me to be my authentic self, I really want to share my story with you, because now you see a picture of a young girl who, at the age of 4, became homeless with her mum and her 1-year-old sister. A young girl who spent more time out of school than she spent in it, and who initially left school without a single GCSE. A child who experienced harm from many who should have protected her, and she became a teenage mother, lived in a relationship where she was made to feel less than worthless, and for a while believed the world would be better off without her. And these are just some of the reasons that that child felt excluded from the society in which they lived. And these are things that she had hidden for all of her life, for fear of being judged, not believed, and for fear that even more people will try and convince her that she is not good enough. And of those, there have been too many. Now imagine this is a picture of a black girl who, on top of everything she had survived, she faced exclusion and racism, and that would be directly related to the darkness of her skin. So the darker her skin, the more likely she would be to be facing levels of racism. Or imagine she didn't identify with the gender that she was assigned at birth, and that she struggled not only with self acceptance, but with constantly having to justify to society who she was. Or imagine that she were gay and her mother told her frequently that she was not normal. So I am certain that for me, just one more additional layer of exclusion or marginalisation, one more door being closed, one more barrier would have definitely pushed me over the edge. So now let me demonstrate to you the power of sharing light. Because now you see a picture of a woman who married the love of her life. He shared his light with her when she was unable to find her own, and walked beside her as an equal, and was the first person to really do so. She has been blessed with 5 children and 2 grandchildren. She attended university at the age of 35, finished near the top of her cohort, and now has her dream career as a midwife, all because someone shared their light. And this is my story so far, but it's far from the end. When I first joined the fellowship, I apologised often for not being more senior because I was the most junior person there, but no one ever made me feel like that, not ever. And this taught me a valuable lesson, and that is that we don't need titles to be leaders. My fellowship and this my life and my fellowship has taught me we don't need heroes. We need people who see us, walk beside us as equals, share strength, power, and light when we are unable to find our own. We might not always get it right, and we need to accept that we will make mistakes, but we must use this discomfort as an opportunity to learn, but never as an excuse to stop trying. And I am proud to be a part of our incredible NHS. And it is the only institution that is thread through people's lives from conception to the grave. And there are so many ways we can be the beacon of light in the lives of many. My history and my present make me unique, and I see things from a perspective that many don't see. I see how our policies, guidelines, and practice sometimes promotes exclusion, even when that's not our intention. And as nurses and midwives, we have so much power and light. We need to be brave and stand up for what we know to be right, doing the right thing, not because someone is watching, but because all too often no one is watching. By demonstrating inclusive behaviours and language, we can become role models to all who engage with us from the cradle to the grave, be that our colleagues, our patients, and their families. And as the largest organisation in our country, we have a responsibility to help address inequality, which is the darkness within our society. We must let our light lead the way. We have an almighty power to change lives and even the power to save them. And it is our responsibility to use whatever privilege we have as a beam that illuminates calmer passage in the darkest and stormiest of oceans, remembering that it is our white privilege that caused the waves of racism, but now yielding that power to turn the tide, not by being not a racist, but by becoming anti-racist. We must stand together side by side and work towards safer and better outcomes for our patients, along with equal power and representation within our NHS workforce. It is in the shadows of homophobia and transphobia we must shine our light and brighten up the darkest corners, leaving it no place to hide, and accept that it is our difference that makes our lives so vivid and brighter than any rainbow. And let's not call it a phobia when really it's ignorance and abuse. We have so much to learn from each other and so many ways we can understand and enjoy the complexity and beauty that is our humanity. And we can show our society how to do this by allowing the NHS to lead the way. And the Dame Elizabeth Anionwu Fellowship of Inclusivity for Nurses and Midwives has for me been life-changing. The amazing people in this photo are whom I have shared so much laughter, many tears, journeys of darkness and stories of hope. And they help me to find my power, my light, and the skills to become an effective and inclusive leader. And to all of those who walked this journey beside me and shared their light, I am forever thankful. But the reason I joined this fellowship was because I wanted to make a change for women and birthing people who do not speak English. And I want to draw your attention to the most recent Embracer report, which was released in 2023. And in maternal deaths during pregnancy and within 6 weeks of birth, 5% of those women that died were women that didn't speak English. VTE was the leading cause of death, followed by hemorrhage and suicide, and then sepsis. And my argument in all of these cases is if you are waiting for the clinical picture to tell you that something is wrong, actually, in many cases, we are too late. So here are some quotes. Now, for those of you that speak Turkish, you may know which leading causes of death those linked to. But for many of us, we have no idea. And actually, if these were being spoken to, you would still have no idea. So my fellowship project sort of revolved around using professional interpreters and the importance of it. So I'm just going to tell you now that first one should read, my right leg is swollen and I have pain. So, and the second one should read, I feel worthless. So those meaningful relationships with women can only be achieved if we're using professional interpreters and not relying on friends and family, because actually by using friends and family, we're changing their role from supporting the women to actually supporting you as a midwife. And also we should be thinking about vicarious trauma when we're using partners and friends and family to deliver difficult messages. The last one of those messages says, I haven't felt my baby move for 3 days and I'm worried, and I'm going to come back to that. So my fellowship challenge initially started off by just trying to create a credit card sized tool that could be used and worn on a lanyard or carried in a pocket with the relevant contact details for the 10 most used languages within the trust that I worked, and with the telephone numbers and the codes to call them. And actually, what I did right at the beginning is I decided to do some very basic research, and I launched a staff survey, and I used some qualitative and quantitative questions on that survey. And to my amazement, it was the qualitative questions that gave me the most detailed information and actually changed what I did for my project. So there were lots of issues that people raised in relation to the barriers of using interpreters, and I've listed the top ones there. So this issue around obtaining consent was quite a common factor, and people saying they hadn't had training or that they didn't have time, and the patients worrying about costs. So what I did from that data is I actually created the card slightly differently. It doesn't look like that either now, it looks much more dynamic. And I created some best practice guidelines that would address those issues that were raised in that qualitative data. And I also then found guidance and policies and merged the two things. So I've put them in a step-by-step order so that you request the same gender interpreter when you ring the telephone number, you introduce yourself and the situation to the interpreter, and then you ask the interpreter to introduce themselves and you to the patient. You then check the dialect is correct for the patient. And I know not all languages have different dialects, but actually it gets really complicated when you start talking about that. And I really wanted to make this simple and usable on the front line. So by just asking that same simple question, is this the right dialect for the patient, to the interpreter, they can check. So that's just simple. Explain the conversation is confidential, that it's a professional interpreter, and that there's no cost, and then ask the interpreter to relay everything you say. And it is this point that you ask consent from the patient, because at this point, I believe it is informed consent. The patient has the right information to make an informed choice as to whether they use the interpreter. And it should never be the partner's consent that you gain, because we would never do that with a white British English speaking woman. We wouldn't speak to her partner and ask him to consent to procedures. We would never do that. So use simple English, speak directly to the patient, using eye contact because you're relationship building with that patient, and then give time to relay that conversation. So those are my guidance, and that's going to be on the back of the card. I just want to go back to some of this data. And after Janet File spoke and came and spoke to us, and she said, you need to go and granulate your data, because I'm very passionate about this subject, and I have been for about 2 or 3 years. I've always been passionate, but the last 2 or 3 years, I've been really actively looking into it. And she said, granulate your data, contact the Office of National Statistics. To any students out there, do you know that you can contact them directly? I'm sharing that nugget of information from the amazing Janet File. So I did that, and I was absolutely shocked. So of all the women on the Office of National Statistics data, aged between 16 and 49, would you believe that only 0.2% of them are non-English speaking patients? But they represent 5% of the maternal deaths. So that 5% looked quite small at the beginning, but now you know that's big. They are actually overrepresented in maternal deaths by 25 times. So simply not speaking English means you are 25 times more likely to die. And I'm physically shaking as I'm reading that statistic, and I always do. But it's not just them. So let's go back to the births and the movements. So there was a rapid review done looking at data in COVID that HSIB did, where they looked at 37 investigations into interpartum stillbirth that took place between April 2020 and June 2020. And within that report, they reported that 43% of those cases where those babies died in interpartum period were in non-English speaking women, or women who did not have English as their first language. And the availability of interpreters was a major issue. So in a lot of the research that I read, and I've read a lot of research, a lot of the issues are actually things that we as midwives at the front line don't have the power to address. So what I wanted to do with this platform, and I'm really sorry that I'm using it for this, but I really wanted to speak to anybody who works in NHS England to really think about what they're doing and making sure that what we do is meaningful. There is clear guidance, but actually who's accountable for the implementation of that? And is it clear enough? And if it's there, actually the frontline staff need to know that. We need to be considering language and communication needs as a protected characteristic, because I believe if we do that, that would be an umbrella that would capture an awful lot of people, not just non-English speaking people, and actually it means that they would be protected by law. And the provision of the fit for purpose interpretation services, because we don't really have that at the moment. It's very difficult to get interpreters outside of office hours. It's very difficult to get the right interpreter, like a female interpreter. And then to create a library of shared resources that all staff can access on certain things like risk of VTE, fetal movements and how important that is, just some very generic things that actually all NHS trusts can access, rather than each NHS trust doing its own thing, because that's such a poor waste of resources. And then also to consider investment in external resources and making sure that these women are included in data, and when they're doing serious case reviews, really considering what impact that language barrier might have on these women. And then again, I've created a list of considerations for trust levels. So things like making sure prescriptions are in their language, but the prescription stickers are for the patient, but yet they're written in English. Well, if you know that patient doesn't speak English, it's pointless. And they don't know what medications they're taking or when they should be taking them. And using simple English. And this is something we're really bad at. There's so much evidence about the importance of using simple English to include all patients. And yet we still hold on to words like obstetrics and put them on letters. And that's a word that doesn't translate if you're using Google Lens. And really to think about how we can use how patients can feed back. So, for instance, the PAL service, I looked at about 15 different PAL services on their landing page. And out of that, only 3 of them had considered the fact there was a language barrier for some of their patients. Only 1 of them had put the information on how to contact PALs through in different languages. So, yeah, it's looking at all of that information. So this is what we need to consider when we're doing this. We need to make sure it benefits the patient and that it works on the front line, and to engage your staff and give them time and the infrastructure to do this properly. But I want to finish with just some stories that have been shared with me, which I've put together in a poem. And this is the very reason that I attended the fellowship and the reason why I want to create this change. Because actually, to me, women-centred care means that every single woman should be treated with equity in order to give them the same quality of care. So these are stories, and I want you to listen and just bear in mind that every single verse is a different story from a different person. And the poem is called Hear Me. You don't know if I'm safe in my home. You don't know if I have the freedom to roam. How can I explain I've experienced harm? How will I know when to raise the alarm if you talk to my abuser to hear me? You haven't involved me in choices of care. I've not attended appointments, didn't know when or where. Just seen the doctor and don't understand the plans. I'm not sure what these pills are in my hand. You've explained to my child and not me. I've questions and don't have the language to ask. I've fears, but you can't see beyond my mask. Intimate issues I need to discuss, but I've come with a person I don't really trust when you speak to my neighbour to hear me. I am nervous and don't know what lies ahead. My experience of birth just fills me with dread. I don't understand what you tried to explain. My informed consent hasn't been obtained when you ask my husband and not me. For when I am hungry, thirsty or low, without an interpreter, how will you know? If I am in pain or petrified by fear, how will I know your concern is sincere if you talk through my family to hear me? Thank you very much.